That one? Okay. Okay. So last week I had you do red and green cards, and I lost them. My daughter decided to play with all of them, and she ripped them up. So I'm just going to have you thumbs up or thumbs down this week. And then at the end of class, my goal, if I remember, because I forgot to do it last week, was to go back and ask you, did you meet the learning objectives that we kind of talked about in the beginning? So first thing I wrote is the outcome. So learn how to describe and integrate family into the postpartum period and enhance the transition. So that's kind of our general overarching topic of the day. And then objectives. So kind of the same thing we did last week. Give me a thumbs up if you think it's good, thumbs down, and we'll talk about it, okay? So work with each other to implement ways to integrate the care of the family and adaptation to parenthood. Sound like a good thing to learn about today? And be honest, I mean, if you don't, it's fine. We can talk about it. Okay? Integrate your experiences with each other and discuss how they did or how they will care for the family as a unit. All right. And then construct a plan to enhance the transition to parenthood and the role of the family by participating in activities and learning from one another. Okay? Anybody have anything else they want to add? Something that you think would be appropriate to this discussion? Okay. All right, so I love baby blues. Always have, always will. And this comic just kind of describes what a new baby is like in, 6 words. And this is how, honestly, a lot of people feel. If whether it's their first baby, whether it's their 5th baby, I think everybody kind of goes through this realization of, at some point in their journey of, now what? I think I go through it every day, I swear. But I thought this was just kind of a nice way to bring about this discussion and this topic. So one of your main goals when you have a patient is to plan for their discharge, right? Something that's kind of hammered in your head as nursing students, that at the moment that they come, you're supposed to start planning for them to go home. And we really don't keep patients as long as we used to. We used to keep patients in the hospital for days and days and days on end. And it wasn't as big of a priority then to get their discharge ready. But, I mean, they might be there for 24 hours, if that. They might be there for 3 days. Even 3 days isn't that long to learn how to take care of not only themselves, but their newborn. So planning for discharge is really important, pretty much right off the bat. So you're going to be not only their caregiver, you're going to be their teacher. You're going to be kind of their mom, mom to the mom, right? It really feels like that. Some patients a little bit more, some patients a little bit less, but that's a big part of your job. So I put the postpartum assessment. I know you guys know this. It's bubble heat. Tell me what the letters stand for. I want you to make sure that you get this so that you can summarize your assessment in one easy to remember way. So I'll just, as I click, they'll pull up, but somebody just start telling me what they're for. What's the first B stand for? Thank you. Perfect. Why am I reiterating this when you obviously already know it? Because it's important, right? Perfect. So this is something that's unique to this patient population. This isn't something you're going to do every day. So I want you to remember it. Because you never know. I've met men that are labor nurses. I've met men that take care of women postpartum. I've met people that never thought they'd be in this line of work, and then they do it. So it's important for you to remember this as you go. And then the only other thing that I would say is when you're doing this type of an assessment, make sure you start with heart and lungs because it's familiar to them, rather than coming in, introducing yourself, saying, can I do your assessment, and then immediately going to palpate or breast. Like, that's a little bit. I mean, we make friends really fast, and I always tell my patients that, but that's a little bit too fast. So starting with your basic heart and lung assessment, that gets them used to your touch, and it makes it a little bit less personal. Lab tests that we do in the postpartum period, and some of this in the beginning here is kind of repetitive from last week because the content overlaps, but I promise it's not all completely repetitive. But hemoglobin and hematocrit are your two that are pretty much going to be tested at least the first day after delivery. assessing for blood loss, any postpartum changes. The UAUC, it's on there. It's not done routinely unless there's some issues that they think they might be having with the UTI or some nature where they would need to collect one. So that's not necessarily one that's done on every patient, but it can be. And then any pertinent prenatal labs that were not done. And why would you not do prenatal labs? Somebody give me a scenario in which a patient might not have their prenatal labs done. Yeah. Okay. No prenatal care. Maybe like she said, maybe they'd just gotten them drawn and then had the baby and the results hadn't come through, because some of these results take some time, right? Like a GBS culture, that takes a couple of days to resolve. One other situation that I can think of that commonly happens that we don't have prenatal labs done. Preterm, yep. That's probably your biggest one. That and late or no prenatal care. So just know that if they are ordering things like this in the postpartum, that's generally the situations that they would be done for. And I'll talk a little bit more about all of that later on. So what are you going to do as a nurse? Obviously, you're going to do your assessments. You're going to incorporate the woman and her family, right? This is a family-oriented unit, a family-oriented time. Pain control. What pain have you seen, or what measures have been used for pain control that you've seen, those of you that have had your clinicals there? Ice packs. What kind of ice packs? Diaper ice packs. And also for C-sections, abdominal ice packs. They're either one. Heat packs, absolutely. Tylenol, ibuprofen, Percocet. Your fresh C-section patients within that first 24 hours, Dilaudid and Toradol are very commonly used. IV route. Safety measures. ID band, that's probably your biggest one, right? Infant to mom or dad, who's ever in the room, preferably mom if she's there, to check the numbers and the name. What else? Not carrying the baby, yep. Not sleeping with the baby. Keeping the crib on the opposite side of the bed so that it's not within easy access to the door. Some rooms that's a little bit easier to be done in, and others not so much, but absolutely. The staff badges that we wear that have the little baby symbol up in the corner. A lot of people forget to tell their patient about that, because it's really easy to just grab a badge, just make a badge or just get somebody else's badge, and without that baby. But if they're not known to look, then they don't know. So if somebody was like an imposter or something. Yep. Absolutely. Make sure that they can get up, walk around on their own. I can't tell you how many people that I've had collapse on their way to the bathroom, either by fainting or maybe their muscles and their legs weren't strong enough yet to get up after an epidural or a spinal. So that's definitely important. Or collapse on the toilet, faint, whatever have you. Just had that happen to me this weekend, so that's always fun. Education. Basically, this whole day is full of education, so we'll just kind of go through that one. Like I said, emotional support, kind of being your patient's mom for a couple of days. Yep. On the way to the bathroom? Well, it kind of depends on what you have around, because we always use 2 people to get them up. So usually if someone's passing out, like as they're walking to the bathroom, if you can swing a chair behind them real quick. If you're close enough to the bed or the couch, I just kind of set them in that. If you don't have any other option, just lower them down to the floor like you would if anybody that's falling. Put your knee behind them and just try to let them kind of gracefully fall down on the floor. The best thing, or what you don't want to do, is try to just hold them up yourself, because you're going to hurt yourself doing that. And they're probably just going to fall over and hit their head or something. But yeah, if they're already sitting on the toilet, I just kind of hold them up right and kind of lean them against the wall if you have to, or whatever. It's the truth. And then start yanking the call aid out, or yelling yelling out in the hallway for someone to help you, or having a family member that's in there run out and grab somebody or something. Usually you can get enough people there, if you can reach like the staff assist button or something, but usually that's on the other side of the room in those situations. So But yeah, good question, because you just kind of have to do whatever you've got there. Sometimes the people that are really shaky, I'll grab a wheelchair just to kind of have available. It's usually the easiest thing to pull behind somebody. But even like if they're their first walk out in the hallway, if they were a little bit shaky getting up, I'll have them do that. Or, you know, if they're going to go visit their baby in the NICU, if they would be there, make them go there in a wheelchair or at least holding on to something. So yeah, good question. Any other questions? Prevention of excessive bleeding. Again, I know that this is kind of repetitive, but I want you to know it because it's important. Any woman is at risk for hemorrhage, right? There are some predisposing factors that make you more at risk, but anybody's at risk for hemorrhage. And I think people forget that sometimes. It's pretty common to say, well, you know, she has no risk factors, because we do an assessment when they first come admitted that tells us, are they low risk, are they medium risk, are they high risk? And if you kind of remember that, and maybe she's low risk and doesn't have really any risk factors, and she still hemorrhages, and it kind of takes people by surprise. So these are all things that we kind of talked about last week, but I put in here so that it would just be a little bit more of a reminder for you. I can't remember, did we talk about weighing pads and such last week when you're trying to estimate how much bleeding that they've had? Oh, I didn't think we did. Maybe. So if you have somebody that's hemorrhaging and you don't really know, we're really good at underestimating blood loss, right? They figure, studies that I've read, figure healthcare professionals underestimate it by about 500 mil. So that's a pretty significant amount when you're trying to figure out blood loss. So what you can do is you can weigh a pad, and 1 milligram is equal to 1 milliliter, okay? So if you weigh the pad and it says 360 milligrams, you know they've lost roughly 360 milliliters of blood. We don't like tar out the pad weight or anything. We just, it's a rough estimate, but it's at least something to go by. You can do that with the Chucks pads they're laying on. You can do that with the pads in their underwear, whatever you have. And the other thing is if you have somebody laying in bed and you're not sure if they're hemorrhaging, and you look between their legs and it doesn't really look like there's anything pooled there, the way our beds are and the way people's anatomy is, blood will run behind them and kind of settle like behind their buttocks. So if you don't roll them over and actually look behind them, they could be sitting in this huge pool of blood that you'd never see. That's happened not that long ago, actually. So make sure you do a full assessment, change out everything underneath them, weigh things, and then do your interventions that you need to do. Fundal massage, of course, being the first thing you want to do. Get in there, start massaging their fundus, and don't stop until you have a cessation in bleeding or you have more help. And then there's different medications, right? You have your Cytotec, your Pitocin, Hemabate, Metrogen, all of those ones that I know you guys have talked about in Skills Lab. One thing about fundal massage is it's not comfortable, and especially not if you're doing it for an extended period of time and really hard, okay? So you're going to have to get their cooperation. Explain what you're doing. Get a second set of hands. I've had women that are so uncomfortable, they're like slapping me as I'm doing it, so I have to have someone else like kind of not hold them down, but at least keep them out of the way so that I can do what I need to do, right? And even if you say, I'm doing this for your own good, you know, you're bleeding too much, we needed this to stop, that doesn't really override anything when they're in that much pain. So
I usually have them, if I'm having to wail on them, I have them first grab my other arm
yeah.
and squeeze.
Mm-hmm.
And then I can assess when they're not, needing a rest.
Yeah, absolutely. So that's a good way to do it. I never thought about doing that. So yeah, that's definitely a good way to kind of gain cooperation and yet do your assessment at the same time. So people that are more at risk for excessive bleeding, those with an epidural, any type of episiotomy or lacerations, any type of instrument, vacuum or forceps assisted birth, somebody with a prolonged labor, indwelling catheter, and then a C-section. So why would an indwelling catheter cause you to be more at risk for bleeding? Mm-hmm. Did everybody hear what she said? Afterwards, you might have some atony, maybe the sphincter's not quite up to par and they might not be able to empty their bladder. I feel like they need to. And remember, a full bladder is one of your main risks for having excessive bleeding because your uterus can't crap down on top of it. So what you need to do is be proactive about keeping their bladder empty, saying you have to get up and go to the bathroom every 2 hours. I had to argue and beg and whatever with my patient this week, and I was like, go to the bathroom. I don't have to go to the bathroom. Go to the bathroom. I don't have to go to the bathroom. I'm like, just go. Try it. I don't have to. I'm like, come with me. So I like had to get her out of bed, and she stood up. She's like, oh my gosh, I have to go to the bathroom. I'm like, I know. Go in there, and the hat's like overflowing. I'm like, see, you had to go to the bathroom. So sometimes it's not like as easy as you think it should be. Just getting cooperation to do that can be a little bit more difficult. If they can't ambulate, try a bedpan first, running a faucet, pouring some warm water over their perineum or kind of like the inside of their thigh. That'll kind of stimulate the brain to be able to go if you're having issues. And this not just postpartum. I used to do this all the time with all my like surgical patients and my older men with prostate enlargement or whatever. I had all these tricks that we would do to try to get them to pee. Sometimes being in the shower, say it's okay, just go in the shower if you can, if that's like the only way that they can go. There's a lot of hesitancy, urgency, that type of thing afterwards too. So, preventing infections is also important. Good hand washing. Like I said last week, make sure that they are washing their hands before they do any peri-care. Limiting exposure to those who are sick, including healthcare staff. It's half your job to keep them, if you're sick, stay home. I know that's easier said than done a lot of times as well. Any break in skin integrity obviously is going to put them at a higher risk for infection than those that don't. Promoting comfort. We talked a little bit about after pains last week. Heating pack, lying prone. I don't think I said that last week. They can actually lie on their stomach or on their side. That can help. Different types of medications that we talked about already. Episiotomy and lacerations, using your anesthetic, your dermoplast. Tux can help. The ice pack that Janaea mentioned. Sitz bath. We don't really use sitz baths too often. At Sanford, I know other facilities use them more than we do. They can be used at home as well. I honestly, huh?
What are sitz baths? Does everybody know what?
I was going to say, I've never even actually used one. I know it's something you can put, it's like a container you can put in the toilet, and then you put, sometimes like Epsom salt, sometimes just water, and it kind of just like bubbles. It's kind of like an itty bitty little,
It's
like a hot tub sort of, but not really.
It's
It's not like warm, but
put it on the thing,
yeah.
and you can hook it up to the faucet, and it sits on the toilet, and their bottom kind of sits in it. It's like a little tub that it sits in, and then the water is just kind of running.
Yeah.
over it. So we stopped using those when all the rooms had Whirlpool
Yeah.
tubs, because really it's kind of
It's
that
basically the same,
motion.
yeah.
But they have to get in the tub, so.
Yeah.
Yeah.
So if you got a C-section, they can't submerge. I honestly, we were looking for one not that long ago, and we couldn't find one. So they don't even probably have them anymore in the hospital. Anyway, here anyway. I don't know. I suppose other facilities do, but
Kind of like a bidet, but
kind of.
it's longer. I mean, you sit there longer.
Yeah. Yeah. So, okay, and then if you don't have a sitz bath, obviously like Whirlpool tub, like she said. Other areas of discomfort, engorgement and sore nipples. That's two big ones that you're going to see. Not so much the engorgement in the hospital, but sore nipples definitely. Making sure the baby has appropriate latch-on technique, giving them hydrogen gel. I'd say really the latch technique is your most important assessment, because if the baby's not latching correctly, they're going to be sore. And I don't say this to a lot of people, but I was probably like one of the only people that never ever got sore when I was breastfeeding my daughter, like ever. And everybody's like, you cannot have a baby and not get sore. I'm like, yeah, you can. I promise you can. So it's really, really important for latch-on technique. I remember right after my daughter was born, I made her relatch like probably 40 times in the first 2 hours. I was like, my mom's like, feed that kid, for crying out loud. I'm like, I am. She will. And she did it. She figured it out, and we never had an issue after that, ever. So that was something that was really important for me, and I know that's really important. And people will kind of get in this, the baby finally gets on there, they don't want to move them, even if it's hurting them. So really promoting education, saying this is very important for you, it's very important for the baby. we could talk for 3 days about breastfeeding, but I'm just going to stop there. But that's why I'm saying it's really important. There's other things you can do if soreness is already occurring. And then engorgement. Kind of talked about this last week too. Ice packs, cabbage leaves, well-fitting bra, binding if they're not non-lactating. I got a little bit more here in a bit. Postpartum, or what?
Okay, wait. One thing when you talk about engorgement that's really critical when you're a baby-friendly hospital, it's really, really important for moms to go home and be able to, not hand express.
Oh, yes.
Okay, hand express.
Yes.
There's a definite technique to it.
Yes, there is.
So that is a critical teaching piece that I think gets overlooked. I don't know if the lactation consultants go over it.
Yes, lactation consultants, I know they do go over hand expression. I'm not super comfortable in teaching people it because I can't figure out the technique very well. I've tried like having other people teach me and I just can't figure out like how to show somebody how to do it. So it's definitely something that somebody should teach them. Even if you're not really comfortable doing it, get somebody who does know how to teach them.
I just told my own group, of course. So it's grasp, push back, squeeze. Grasp, push back, squeeze.
It sounds so easy.
Counterintuitive.
It's absolutely counterintuitive to what you want to do.
That's how you should do it.
Yes.
Yeah, I know, right?
So, yeah, it's something that every mom should know how to do.
Squeeze. You want to grasp, push forward, and grasp and squeeze, but you have to grasp, push back, and squeeze.
Absolutely, yeah.
We'll work on that later.
I don't have the reason to anymore. There's nothing here. It's gone.
I did it.
Yes, you did.
Yeah, so I think there's still some knitted.
Well, I know how to do the technique. I just could never get anything to come out. That was my problem. That's a little too much information for you guys, isn't it? Is there such a thing as too much information when you're talking about this stuff? Probably not.
I never think that.
I'm seeing nodding, and I'm like, yeah. All right, so moving on, postpartum fatigue. It's actually a phenomenon that's it's not just being tired, it's being like exhausted, tired. So many women have this. They probably don't realize they have it. Many healthcare providers don't realize that the patients are having issues with postpartum fatigue either. And a lot of times the reason we don't pick up on it is because in the hospital they have support. They have nurses to help. They have family that comes and visits. They have a lot of social support, their partners there. Going home, they might not have all of that support. I mean, they definitely don't have the hospital support. They don't have people cooking them meals anymore. They don't have people doing their laundry for them anymore. Their other kids are home, or they're home with their other kids if they have them. So it's something that's associated with the birth process. Was it a long labor? Was there other issues? Maybe they had some type of a health condition associated with it. Just the hospital routine. I mean, people say they're going to the hospital to rest, and I think that's the biggest lie that I've ever heard. People don't rest in the hospital, I don't think, hardly ever. And then just having the demands of a newborn. I mean, babies are up all the time. We say every 2 to 3 hours that they're fed, but they're up way more than that. So just all of that, that piece of it. And then your body's still recovering. They're anemic. Maybe they have thyroid dysfunction. Maybe there's some other underlying factors that are going on that are causing them to have increased fatigue. What I see a lot of the times is patients that maybe their baby's finally sleeping, but they have so much adrenaline, they're so excited, there's so many hormones running through that they just can't sleep. They just don't sleep. They just sit there awake, and they're just not sleeping, and you just want to be like, go to sleep. And they're like, I can't sleep. It's a really weird feeling when you're so tired, but yet you can't sleep. So if you know anybody has these risk factors, if you know people are kind of showing those symptoms, it's good to intervene beforehand, see what kind of social support they have at home. Do they have somebody that can come home, not necessarily take care of their baby, but maybe can somebody do their laundry for them? Can somebody take the other kids for a couple hours to give them a little bit of a break? I told all my visitors for the first couple weeks, you can come over and see the baby as much as you want. You just have to bring me something to eat, too. So I had casseroles like crazy. So That was my condition for visitors. So something like that. And, you know, I've told lots and lots of patients that too. So the thing about...
I'm sorry.
That's
Another
okay.
thing I would think about is all of visitors in the
Oh.
hospital. If I had my way, the world would be a dark and dreary place. No one would ever be able to come visit my
I wish we could restrict visitors to literally to the, like, spouse or significant other. Like, that's it. Yeah, when we're on visitor restrictions for like influenza and stuff, it's so much nicer because, I mean, it sounds awful, but like there's visitors there all the time. They never let them rest. Babies don't breastfeed on time. They get so overtired. Moms are like crying at 4 o'clock in the morning, uncontrollably because they're exhausted. It's like visitors make things so much harder than they have to be.
Yeah,
So.
I think it's a major contributor.
Oh, absolutely. I totally agree with that. So if any of you have kids or going to have kids someday in the future, tell all your visitors stay home. You will thank it. Come to your house. Come to your house. Mm-hmm. The thing about postpartum fatigue is the symptoms of it kind of are interrelated to postpartum depression, and then they kind of feed off of each other. So if somebody already has postpartum depression or is at risk for it, postpartum fatigue is definitely not going to help it. The way you can tell the difference is if somebody with postpartum fatigue, their symptoms will kind of lessen if they do actually get some rest, some good quality rest, whereas postpartum depression, not so much. So that's kind of how you tell the difference between the two. But they definitely are interrelated. So that's another big thing that you need to watch for. Any questions on any of that? Okay. Ambulation and exercise. Page 492 in your book has a really good chart of different exercises somebody that can do. You know, getting them up and walking is huge, associated with less risk for embolism, clots, helps them return to healing faster. If they're lightheaded or dizzy, kind of like she asked earlier, definitely not the time to be doing a bunch of exercises, but it is important to let them know that they need to be up and walking around. And this can be a little bit of a cultural context too, and there's a lot more later in the slides about culture. But some cultures, it's very appropriate to stay in bed and to let other people take care of you, and that's just the cultural norm. And that can be incredibly difficult when, you know that science says you need to be getting up, you need to be moving, you need to be taking care of yourself. So you need to assess anybody that's had some type of an epidural or spinal anesthesia if they can stand initially. So what we do is we have them put their feet on the bed and lift their butt up. If they can do that, that's generally a good indication that their thigh muscles have returned enough strength so that they can walk around. So that's the first thing that they should be doing, and not being able to use their hands when they do that. So they're laying on their back, they put their feet underneath, and then lift their butt off the bed. If they're already standing, have them do a couple deep knee bends or squats. That'll also help you to determine if their muscle strength is adequate. If it's not, don't get them up right then. As far as exercises in the whole postpartum time frame, starting simple, use it, not doing so many abdominal things for at least 4 to 6 weeks, but doing other exercises, walking, maybe swimming, something that's not super vigorous. And then Kegel exercises, and I'm not even going to go to Kegel exercises. I think we had enough about that last week. I couldn't remember who said it, so I was just like, we know about Kegels. Nutrition, dietary needs. A lot of people have questions about what they can and cannot eat in the postpartum time frame. People who are not lactating, about 1,800 to 2,200 calories a day is sufficient. Lactating women, your book says 450 to 500. I've always known about 300 additional calories. So it's not like they need a whole bunch more calories, just enough to support lactation. And then they should also be including DHA if they're breastfeeding, so that it passes into their breast milk. So 200 to 300 milligrams of DHA daily is sufficient to pass in their breast milk. Some get that through multivitamins, some get that through low mercury fish. What's the word for DHA? Deoxy ribonucleic. I'll look it up on break and get back to you. I can't remember exactly what it stands for. Basically, it promotes brain development in the baby.
It's
So,
like,
It's something nucleic acid.
It's like a protein.
Yeah, it's found in fish. Low mercury fish is best, so that you're not having issues with the mercury. But it's either in fish or it's in multivitamin, and what it does is promotes brain development for the infant. Formulas are often fortified with some DHA in them as well. So, but honestly, I can't remember. I'll look it up on Break and let you know what it actually stands for. Okay, I'll get back to you on that. Encourage them to take their prenatal vitamin for at least 6 weeks. I always tell people that are breastfeeding, just take it the whole time that you're breastfeeding, just because multivitamin is important for them. Passes on the nutrients to their baby as well. And then anybody that's anemic, they might be prescribed iron. That actually is pretty common in the postpartum time frame to be prescribed iron, instead of doing like a blood transfusion or something. So you need to promote bowel and bladder function, kind of like I said before. Make sure that they're emptying their bladder completely. That's a big part of it, not just that they're going, but that they're actually emptying their bladder. They often have times with urinary retention, just because of the decreased tone and stuff. So everybody did really good on the bowel function on their worksheet, so I know you guys understand that. Breastfeeding. When you're promoting breastfeeding, you want to initiate it at least 1 to 2 hours after they're born, as long as the mom and baby are both stable and able to do it. Starting skin-to-skin contact right after they're born is great. Not absolutely necessary for bonding and for initiation of breastfeeding, but it definitely helps. And then observing for feeding cues. This is one that a lot of women need a lot of help with, is to learn their baby's feeding cues, because they think, oh, the baby's sleeping, they're not hungry, they're fine, where maybe they're missing all of their feeding cues. And this is another reason why visitors are such a hassle, because I've seen baby get passed and passed and passed and passed around the room, and then they don't eat for 4.5 hours because they got rocked back to sleep and no one ever paid attention to the feeding cues of the newborn. And then mom's into low supply issues, and the baby won't latch on, and then they wake up starving and will not latch on, and then mom's frustrated, and it just cascades into this whole awful cycle. So really instructing them right away on what feeding cues are. Can anybody tell me what infant feeding cues? I know you should, because I went to your skills lab. I know you know, or should. Rooting, yep. So they're kind of looking around, trying to chew on their blanket or their hand, whatever's around their mouth. Yep, smacking their lips back and forth. Yep, the rooting reflex. That's okay. No, it's different. I mean, it's different, but it's rooting reflex if they initiate that. Yep.
Is that the same as when they I don't know, you put them up to a chest or whatever, and they kind of go crazy? Those little chicken
Yeah. Oh yeah. Oh yeah. It's partially the rooting reflex. It's partially the. I mean, they know their mom's scent different than like your scent, but oh my gosh, when I was still nursing my daughter, I'd have babies that were like on me all the time. I'm like, no, this isn't for you. All the time. So yes, they definitely know that. And I've seen them do it with guys too, so they're not. It's the truth. So basically just educating them on what feeding cues are and not to miss them if they see them, not just to kind of rock them or give them a pacifier, because a pacifier is going to have them produce oh goodness, the word just came out of my mouth. It's going to make them feel full. So if they give them a pacifier, they're going to miss a feeding. And just like I said with visitors, it's just all going to cascade into a problem. So.
So when is the best time really to get a baby skin to skin to start feeding? Something you should know that. Exactly.
Mm-hmm.
So I would teach parents if the baby's eyeballs are moving under their eyelids, that's a great time to prepare and get ready for feeding, and just put baby skin to skin.
Yep.
Many people think crying is a feeding cue, and
It's not. It's like you missed the feeding cues, and now the baby's like really, really mad at you. So now you're going to have to start over, because it's not going to work. Because I've never seen a baby that's screaming its head off be able to actually latch on and eat. So, and this is, especially the moms that are very, very set on breastfeeding, and this is like all they've dreamt about their whole pregnancy, and they're having these issues, it's very hard on them. It cascades into all the other stuff we're going to talk about, all the social support and the emotional responses and all kinds of stuff. This is a really big thing, okay? So doing what you can to help them is going to be very important.
I told the last mom that I was working with that when you see the baby's eyes moving back and forth, they were having
Oh, there you go.
so it was kind of
That is a good way. Absolutely. It does. All right. So on the other end of the spectrum, the women that want to suppress lactation, right? So they don't want to breastfeed. They don't have a desire to. We're not going to judge them for it. We're going to help them in, so that they're comfortable. So well-fitting support bra, binding their breasts with some type of an elastic ACE band, continuously for 72 hours. And this, I never see this started right after delivery, and it should be. And it's really hard when you're coming in day 3, they're going to go home and they have had nothing and they're getting engorged. And now you're trying to play catch up and try to do this for them. So it's really important that if you know somebody's not going to breastfeed and they are for sure on that decision, to get intervention started right away, because it's only going to help them in the long run. So teaching them, avoid stimulation. Don't run hot water in the shower over your breast. Stand with your back to the water. No heat. Use ice packs, use cold cabbage leaves, whatever that you can do. Some type of anti-inflammatory, because remember, what is engorgement? I know I said it last week. Is it insane amounts of milk? Inflammation, blood and lymphatic fluid, right? So knowing that, you can teach them ways to decrease that, right? Because you don't want them ending up with mastitis and clogged ducts and a bunch of issues going on from there. So looking ahead to future pregnancies, there's things that we need to do right after delivery if mom meets certain criteria, right? So vaccinations, your rubella. Why is rubella important, or who would it be important for? Okay, mom. Yep, you're right. It's for mom. Why? Why do we give rubella to every mom? Yep, the ones that aren't immune. So most people, when they get the MMR series as a child, they become immune to the rubella virus, or if they acquire the infection, right? Sometimes women aren't either. They've never been exposed, they never got the vaccine series as a child, or they just never converted to the antibodies for the rubella virus. And the reason why we are so worried about rubella is not for this mom right now. It's for if she would get pregnant again and would acquire the rubella virus. It's very devastating to the infant in the first 3 months of fetal development. It can cause brain damage, it can cause other malformations, it can cause the baby to die. So we want to make sure that to help a future pregnancy, that she has at least the option to be immunized against the rubella, and so we offer the MMR in those women that are not immune. If they get the MMR vaccine, it's a live virus, so if they're getting that, they have to wait at least a month to become pregnant, because their body will develop antibodies, and then the same thing as actually acquiring the virus could happen to that baby. So that's important to tell them. I mean, they shouldn't be having any intercourse anyway for 6 weeks, but we all know that that's not the real world all the time. So basically, same thing with varicella. That's not nearly as often given to women in the postpartum period, but it can be. Again, a live virus vaccine, so they have to wait 28 days or a month to become pregnant. And then the Tdap. So Tdap is offered during pregnancy. Does anybody know why? So the Tdap is tetanus, diphtheria, and pertussis. Yep, pertussis is whooping cough. So we give pregnant women the Tdap vaccination with every pregnancy, because she'll pass on some of that immunity to pertussis to the infant. If they're not immunized during their pregnancy, it's good to at least offer it to them in the postpartum period, because it takes about 2 weeks to develop the immunity to it, but at least it kind of helps to protect the baby, because you can't give a baby it's not the Tdap, it's the DTaP, it's just the infant version, until they're at least 2 months old. We also recommend that any immediate family members, siblings, the father, grandparents, whoever's going to be around the baby a lot, also gets their Tdap. before the baby's born, preferably at least 2 weeks, just so they have time. So that's why that one's up. If anybody in the household is very immunocompromised, though, they should be warned about getting the live virus vaccines because they could potentially give that virus to somebody who's severely immunocompromised that lives in the house with them. So you got to kind of assess the whole family situation as well. RH ISO immunization. Who knows what I'm talking about? What is this? Why do we care about this? RhoGAM. What's RhoGAM? I'll give you a break after this slide. Perfect. Did everybody hear what she said? Okay. Why do we give RhoGAM to during their first pregnancy? Because it's not affecting the baby. It's not going to affect the first baby because mom's body hasn't had time to develop antibodies yet, right? So if you got your Rh negative mom and your Rh positive baby, it takes time for her body to develop antibodies. So why in the world are we giving it to the first baby? But why are we giving it to her during her pregnancy and right afterwards? We give everybody that's negative during their pregnancy because we don't know if they've ever had a miscarriage in the past and had a potential for fetal blood to mix in. So every mom, regardless of how many pregnancies she thinks she's had, gets an RH at 28 weeks and then again within 72 hours of delivery. The 72 hours of delivery is because there is trauma. There's potential for fetal blood to mix, probably more so than at any other time. And the only time we give it postpartum is if the baby actually is Rh positive. If the baby's Rh negative and the mom's Rh negative, there's no need for RhoGAM because there's no antibodies that are going to be formed. So every Rh negative mom, the infant's going to get a type and screen on their blood so that we can determine if they're Rh positive or if they're Rh negative. So you might have that situation where she got her RhoGAM at 28 weeks because we don't know what the baby's blood type is. And then after delivery, we find out the baby's Rh negative and she doesn't need RhoGAM. And she's wondering, well, why did I get it while I was pregnant? And you're not going to give it to me now. Okay, that's the situation. If the baby's negative, she doesn't need it.
So does everybody get that?
That's a big concept. Is this really
Clear to everybody, or is there some confusion? Why we give RhoGAM in the first place, and when we give it?
Who can tell Ann what we talked about while she was out of the room? Can anybody summarize the last couple minutes of class?
RhoGAM is given at 28 weeks in case there is a past pregnancy that the mom wasn't aware of. And then it's given within 72 hours postpartum if the baby is Rh positive and informed. So that if the blood mixes, there won't be any antibodies.
Yeah, in case there was any blood mixing. Exactly.
Yep.
And in the next unit, we'll see exactly what a baby who had that ISO immunization, because mom didn't get RhoGAM before their pregnancy, what that baby might look like. So, not pretty.
Yeah. So it affects the baby, not the mom. Yes, that's important to know. It's made from human plasma, so it could be considered a blood product. So think about people that might not be willing to accept a blood product. Jehovah's Witness, right? They might have an issue with getting RhoGAM. So it'd be kind of a case-by-case basis. That's what I was reading about in your textbook. I've never really thought about it that way.
Have you ever heard of that?
I honestly don't know if I've ever actually taken care of somebody who refused a blood product in this setting. So, but just so that you know that it could be considered. Nope. There's no any Rh positive mom has nothing to worry about because she's not going to develop any antibodies. It's just if she's negative. Okay, and if she's positive and baby's negative, it doesn't make any difference. Did you have a question? Okay.
Have you guys ever seen a baby that was maybe born like preterm and the mom wasn't able to get RhoGAM yet?
Personally, I've never. Have you?
No, it's not usually
Yeah.
Different habits. Yeah.
So, yeah, good question. Honestly, I've never encountered it. But
Okay, so it doesn't affect the mom, it affects the baby if she doesn't get it?
Right,
Mhm.
right, because she's building up antibodies. So
To the
then
baby.
when the mom is building up antibodies towards that Rh positive because it recognizes that it's not the same as its own self, right? The mom's body is seeing something that's not the same, and so it would attack that baby, the next baby that's there. Yeah. Right.
I always think of it sort of like, I mean, it's not really, but kind of like your organ transplant, how the body recognizes that it's not itself. That's what it does. Yeah, it's rejecting the baby, the pregnant, or the fetus. It's not the baby, it's the fetus. So
Way to think of it.
that's how that's how it sort of cleared my head, I guess, is to think of it in the same context of an organ transplant. So. Is that just clear as mud?
We've
Okay.
talked about this
Yeah.
a fair amount.
All right. Go take a break. Everybody needs one.
That's in order. Oh, yeah, Megan Turner too. Little circle. Are the Danny people. Mr. Parker coach on, not so much.
I don't feel bad. I don't know if any of my teachers knew my name until I graduated. I swear, because I never said anything in class ever. All right, DHA. Now, don't make fun of my pronunciation. Docosahexaenoic acid is how you say it, and that's what it's called. It's a polyunsaturated fatty acid that you get from 1 to 2 portions of fish or a multivitamin. So there. Yep, that's why I call it DHA, because that's a lot easier to say. Yes. Yeah, if you ever look on like vitamins or on baby formula or whatever, it'll say like DHA added on there. That's what it is. Makes you smarter.
And that's newer
Newer, yeah.
in the last, I don't know, 20 years. For me, that's.
I was going to say, I've always known it, but hey, we're not going to go
When
there.
I first started working, there was no such thing. Let's just put it that way.
All right. So kind of the rest of this is looking at like transition needs, like psychosocial needs, how you can help not only the woman, but her family members and stuff as well. And then towards the end, it's kind of the variations in normal transition, maybe special circumstances and stuff. But so complex needs that have to be addressed in the postpartum period. Reaction to the birth experience. That is one that a lot of women want to talk about the first few days. It's still very fresh in their mind. Maybe they need to reconcile what they had planned to what actually happened. And I actually had a patient probably, it's got to be close to a year ago now, but she had planned for like no interventions, no epidural, no nothing, ended up with like an emergency section, and she was like, I've never seen somebody that was so upset because of the way it happened. And she like couldn't take care of herself. She couldn't take care of her baby. Her husband couldn't help her because he was upset with her. It was this dynamic that was just, I had never encountered it to that degree. So I'm pretty sure I just ended up pulling up a chair and sitting with them for probably 2 hours, just talking about what had happened, all the events that had led up to the C-section. Kind of, she felt guilty about it. She thought she could have done something differently. Why didn't she know this could have been an option? I mean, it was just something I had never experienced. So I learned a lot from that experience and how important it is for people to kind of reconcile their image in their head versus what really happened, and to kind of be able to integrate that and then not kind of move on from that too, so that they can take care of themselves, take care of their baby. And I actually ran into her I don't know if it was like a month after they had been discharged. I think it was at Well Baby Clinic or something. And I bet you she talked to me for 45 minutes about how helpful that was and how she went home with such a different attitude and stuff. So it was really cool for me to be kind of on both sides of it. And then her husband as well, because he was just as suffering as she was. It was crazy. But So that's something that people kind of need to reconcile in their head. They may want to talk about it, they might not want to talk about it at all. So they have new identities as parents. Even if it is not their first child, they still have a new identity as this baby's parents. How's this baby going to fit into our family? How is our life going to change now with this addition? A lot of self-image issues. People kind of expect to go to sleep and wake up and they look like they were before they were pregnant. That's just not reality. So kind of warning them on that, saying, this is going to take some time. You will get back to your pre-pregnant state if you work at it, but just know that it's something that's not going to happen, instantly overnight. Sexual concerns are really big. People don't want to talk about them. Just being open, direct, honest with your patients, saying, I'm doing a whole assessment and that includes this. Do you want to talk about it? Do you want to talk about options, for birth control, about when to resume, what happens if they are not interested at all? Hormonal changes, like the dryness and stuff that we talked about last week, that can make people very uninterested. Just having a new baby, being exhausted, not wanting to take the time. Maybe they're very attuned to their babies. If their babies cry, they think that the baby can hear them, all kinds of reasons. So different people resume at different times. And it's really just like anything else in nursing, just to be open and honest, and it's not weird to them if it's not weird to you, okay? Reaction to the infant, talk about a little bit more, but kind of the same thing as reaction to the birth experience. They've been building up this baby in their head probably before they ever got pregnant, definitely during their pregnancy, and imagining what this baby is going to be like. And they have to reconcile that image with the baby that they actually have. Sometimes it's very close, sometimes it's not. So, cultural diversity. There's actually the section in your book. If you don't, I get it. I don't read everything I'm supposed to read in school either. But if you read anything in the book, the 2 pages or whatever it is on cultural diversity is very interesting. I didn't know some of the things that were in there until I started preparing for this class. But a lot of restrictions in certain cultures about activity, rest, diet. Like Asian cultures, the balance of yin and yang. Pregnancy is seen as like a hot time. So in their postpartum, they're cold, so they're doing things like eating what is considered to them as hot foods, like rice and meat and stuff, and then not showering, keeping the room really warm, just whatever they can do to balance out the coldness of their postpartum state versus the hot of their pregnancy. So just doing different things like that might seem really strange if you're not part of that culture. And I've been in situations where people have done things that I thought were a little bit different. I had I don't know if it was sage leaves or what they were burning, but oh my goodness, it was very strong. And they had some like chanting music going on and like an amulet the baby was wearing, and I like walked in and like not knowing them at all, I answered a call light, and it kind of took me off guard a little bit. I'm not gonna lie. But I can't remember. I can't remember, to be quite honest with you. I was like literally like going off of my last shift and I answered a call late like the last 5 minutes. I didn't really dig into it. But biggest take home thing at any cultural practices is as long as they're safe and they're not hurting the mom or the baby, and it's not our job to judge them about it, to incorporate it as much as we can, and then also not to assume because somebody is part of a certain culture that they're going to follow all of the customs and all of the practices. They might follow it sometimes when their family's present and might not at other times. We just need to ask and be open and honest about it. And even if it's something we don't per se understand, it's okay.
The hospital likes to burn stuff?
It depends on what type of thing they use. You can't light a fire, no. But if you use like a certain, yeah, it depends on what they use and if they get it approved or not. But yeah, they're not going to like sit there with an open flame, no. They're not going to be that okay with it. But all right. Kind of again on discharge teaching. I know this is a little bit repetitive, but follow-up visits. I just kind of want to jump down there. Generally 2 weeks for 2 and 6 weeks. For a C-section, and then 2 weeks or 6 weeks for a vaginal delivery, unless they have some type of other issue. If they're really high risk for postpartum depression, maybe they have limited social support, maybe there's some other reason, they're often seeing them sooner. I actually had that experience this weekend really high risk for postpartum depression. Baby went to the NICU unexpectedly, had other issues going on at home, so I think the provider was going to see her within a week or something. And that we kind of had to advocate for the patient to be seen earlier. So that should be 6. Yes, it should be. Thank you for catching it. Did not see it at all.
Did that on purpose.
I did. I got to make some mistakes. I can't be completely Mary Poppins here. But yes, thank you. Sorry, I should jump back up to contraception in the postpartum period. Various methods that they can use. Some use natural family planning, even though that's a little bit less reliable in the postpartum because you can't track like ovulation and stuff as easily as you can before they get pregnant. Condoms, foams, spermicides. Sometimes they have an IUD placed within that postpartum time, sometime around that 6-week mark. Some people actually get tubal ligations during their postpartum. Sometimes if they have a planned C-section, they'll have a tubal ligation done at the same time. So it's just kind of whatever works for their family. Okay. So this is the start of chapter 22. I just kind of put that break in there so you kind of know where we're at if you're following along in your book at all. But so this is really about attachment, bonding, behaviors that infants and parents do to promote that bonding, things to watch for if it's not occurring in the, probably not necessarily the way it should be, but different steps than what you normally see and stuff. So the stuff that I have in bold are just definitions per se. You should know it, yes, but I bolded it because it's the definition taken straight out of your textbook. So just for clarification for that reason. I don't know if Ann does it a little differently than I do, but that's why I did it. So attachment, bonding, kind of interchangeable, basically the process where the parent loves and accepts their child and the child returns it back to the parent. A big piece of your nursing assessment is to watch for bonding and attachment behaviors. If you note that maybe they're not, naming the child, not taking interest in the child, barely providing caretaking tasks, they're high risk for, maybe abusive situations, maybe neglect or something later on. And it's your duty as a nurse to report these things. I have filled out the 960, the mandated reporting form, just for issues with bonding when I've thought that maybe they're going to go home and have maybe failure to thrive or other issues with neglect with the baby. I mean, it seems like it'd be kind of crazy to do it for that, but if it's that apparent, then it's something that they need to at least be followed up with closely.
Jess,
No?
you probably do not have time for me to talk to you.
That's fine.
But, this one time, when I had students on the floor, we had had this baby, and the mom was 18, 19 years old, and the baby had been cool all day. This is why we use 98 as our normal instead of 97.7. But what happened to this baby, it got admitted to NICU, but it did go home with mom. The whole time, mom had a flat affect, didn't really do anything with baby. And within a month, that baby had died at home. And it wasn't like something that you could put your finger, and it was neglect. The baby died of neglect, not because the temperature was cold. But it wasn't like anything that you could say she was, abusing her baby or had abused the baby. She wasn't, positive for drugs when she came in or anything. But it's way better if you have a suspicion to make sure that there's going to be some follow-up in the home. That was a big lesson, I think, for everybody.
Mm-hmm.
Incredibly scary.
Yeah.
And it was just kind of like, ugh, she just was not attaching to that baby. And
Yeah.
She just was kind of flat out. She wasn't excited at all. And nobody really did anything about it.
Well, that's the situation that I was in with that. Just the same. I mean, I don't ever know what happened to the baby afterwards, but just the same thing. Just very flat, very uninterested. No, you take care of it. You do it. Can the baby go to the nursery? Just total separation of what you would assume. So, and remember, I mean, it's a cultural context. Some cultures, the baby is cared for by others in the home because mom wants to focus on her rest. But as long as the baby's being taken care of, and somebody's at least interested in the baby and his or her well-being and stuff. But so kind of going back to this, like I have on here, fantasy infant versus real infant. That's what I was talking about. The baby that they had in their mind versus the baby that they have. I've seen a lot of more, not so disinterest, but more like if they really wanted one sex and they got the other. That's been one that I've seen a lot. If the baby has some type of malformation or a problem or something that seems like that is a little bit harder sometimes for parents to attach to. Those are, I guess, probably the two biggest ones that I've ever seen. But a lot of people are really keen on early contact, immediately skin to skin. That's the only way your baby is going to bond with you. Well, obviously that's not true, because how in the world would babies who are adopted ever love their parents if that was true? I mean, Anne's a perfect example. So, I mean, it's not that it's absolutely necessary and that babies will never love their parents if they don't have early and close contact, but if they have the ability to do it and everybody's willing, it's definitely good for everyone involved. And then just to reinforce people, because I've had moms say, I thought I was just going to immediately love this baby, and I don't. They're really tired. They're really stressed. The expectation's different than what it turned out to be, and they feel bad because they don't just immediately have this a great love for their infant. And just to reinforce that it's okay. Attachment takes some time. It doesn't always happen the instant that the baby's born, and that they are reassured that it will come eventually, and that they will grow to love their child in the way that they thought they would from the moment they were born. And I see a lot of people that have a lot of guilt over this, and they really don't need to, because it's a process, and they need time for them to heal for themselves as well as to get to learn their infant. But you can be really motivational for them, point out the things that they're doing well, point out the things that are going well, and maybe if there is some problem with the infant, point out the things that are good, or whatever have you. Encourage them to see follow-up, that type of thing. That'll all help in the long run. This one is kind of talking about senses and how parents and infants use their senses to get to know each other. Touch, it's extensively used for newborns. People are always rubbing them, stroking them, exploring their skin right after they're born, everything. The eye contact, the mutual gazing, that's when the baby's sitting like right in front of the parent's face and they're looking at each other. That's very rewarding for people if you can help them, to do that and to point out like, look, they're looking at you, they're paying attention to you, they're mirroring your facial expressions, that type of thing. That's huge. Babies are able to distinguish voices of their parents, especially their mom, before anybody else. That happened once. I had this mom, she's like, I bet she told me about it every time I walked in the room for 2 days. Like, my baby responded to my voice, and I know she loves me, and this is great. And literally the baby had turned to her right after delivery, and she was so over the moon about it. And I was just like, yes, it is. It's great. Your baby loves you. You love your baby. We just went with it. It was great, though. She was so into it. So usually it's not that apparent, but she was very excited. So I just went with it. You got to be a cheerleader a lot of the time. And then odor. Babies know their mom's odor. When they're breastfeeding, it smells like their amniotic fluid. It feels safe. It feels like home for them. There's a lot of words, terms in this slide here. Entrainment, it's like their movement goes along with their adult speech. So they're moving their arms and legs. They're kind of wiggling their body along with their parent's speech. So that's what that's all about. Biorhythmicity, infants in tune with their mom's rhythm, so their heartbeat's very soothing. I kind of have a funny story about this. We got one of those baby sound machines that we got as a baby shower gift. So we turned it on 3 days after we got home, and we turned it on the heartbeat setting because everyone's like, oh, they're really calmed by the mom's heartbeat. And both my husband and I are laying in bed because she's in our room, and we've got this heartbeat. He goes, I feel like I'm in a horror movie. I don't think I can do this. So we're both laying there listening to it. I'm like, nope, we got to change it. We can't do this. So my daughter missed out on the heartbeat sound because it was really creepy. But in theory, that should work well if you can get over the creepy horror story behind it. But and then reciprocity is like baby cries, mom picks baby up, baby's happy. That's kind of where that goes. And then synchrony, and then the fit between the cues and then what mom says. Basically, this is determining what their cries mean, because they cry differently when they're hungry, when they're bored, when they're wet, when they're tired. When you look at them funny, I swear. So just learning those cues and telling them that it's going to take some time for them to learn those cues, and that it's okay that they don't know them right off the bat. Transition to parenthood. Back in old times, it was thought as a crisis in your life, that it was something that was this huge crisis time, and all these interventions need to be. Now it's more looked at as a developmental transition and more of an opportunity rather than a crisis. So just have them think about it like that versus the crisis time. And then just know that every member of the family is going to need some type of role adjustment. Mom, dad, siblings, grandparents, everybody involved. Becoming a mother, there's 3 phases that your book lists, and the time frame. When they did this study, it was back in 1961, and this is when people stayed in the hospital a lot longer, so the time frame was a little bit more stretched out. Now I think it happens a little bit faster because people go home so much faster. So the first is your taking in phase, and this is when mom's really dependent, kind of focusing on her own care, involved with baby's care, but mostly needs a lot of support, encouragement, nurturing from her family members, from you, from everybody involved. Usually the first couple of days. And then they move to the taking hold phase, which is more of a dependent, interdependent. So they're more involved with baby's care, kind of going past their own needs so much. Still need a lot of help, but they want to take charge. They want to be involved. They want to be the one that makes the decisions. And then they need to be reinforced what you're doing well. Letting go is your interdependent phase. That's when they, you always need support, you always need help, but it's kind of when they're moving forward, they're reasserting their role with their partner, resuming more of what their normal day-to-day life is now with the baby involved. Kind of going into that is your postpartum blues, which can really affect how they go through these stages, or phases, Postpartum blues or baby blues. Anybody know when they peak, when they resolve generally? Yep, so if they last longer than 2 weeks, you should be seen, but usually peaks around day 5, usually resolve by day 10 or so. They feel like they're on an emotional roller coaster. We don't know exactly why it happens, but we know it's a combination of hormones, fatigue, insomnia, just the care of the newborn, sadness, anger, maybe a whole bunch of different things, but to warn them about it, because you're not generally going to see this start until after they've gone home. So to educate the people that are with them and say, look, this is what's going to happen, support her through it, don't make her feel bad because of it, and so that they know, so they're not completely caught off guard. And I always tell the significant other, the parent, whoever's with them, to watch for not only postpartum blues, but postpartum depression, because they're the ones that are going to recognize the signs more often than the mom herself. So we have a little pamphlet that we give them in their admission packet, and I hand that to the significant other. I say, read this so that you know if any of these things happen, then you can be more aware of it and give her the help she needs. So that's really important. It's important to involve the partner, significant other, whoever, in all of the stuff, but that's one of the big ones. Dads go through transitions too. Changing their expectations, their role. They don't really know how to fit in anymore. Now they're not only the provider, but they're the caretaker of their child. So it takes, and I feel like they don't get the recognition. They kind of feel excluded from the follow-up, from the visits, from mom's life, because now she's not necessarily his main support person. She has to take care of the baby. So they go through expectations, or through phases as well. So the first one's called expectation and intention, where they have this they've built it up in their head, they're going to be a really involved dad, and then it kind of goes into confronting reality. This is what the situation is. It maybe didn't quite mesh up with what they thought it was going to be. Maybe they're trying to go along with how they were raised. Maybe they're trying to go completely against how their dad raised them. So then they go into the role of the involved father, becoming more of the baby's life, being more helpful in baby care, getting some feedback from the infant. Maybe they start smiling at them, recognizing them when they walk in the room and such. So just know that dads go through it too. They need to understand that they're not only going to adjust to the baby, but to each other and their new roles and stuff too. So this kind of just goes over that in a nutshell. So there's different, this is kind of the last section in here. So diversity and transition to parenthood. So when you think about age, you think about those that are really young or really old. Not really old, but in postpartum pregnancy, advanced maternal age is 35 plus. So somewhere in the adolescent to the 35 plus, those are your two ends of the spectrum. So your adolescents might have a harder time transitioning. Generally, with the right support, they can do okay, but they have their own developmental needs to take care of. Might have more issues, higher risk for preterm birth, fetal abnormalities and everything just because of the adolescence, maybe because of choices they made prenatally or whatever. But they often will say they feel different. They have to grow up overnight. They don't feel like they fit in with their peers anymore. They have to be an adult maybe when they're not ready to. So they struggle with this a lot. We see a lot of adolescent pregnancy. Some contexts, it's pretty normal in that group to have younger women or teens that are getting pregnant, but it's a big issue in society now, and to do things to help prevent it is something we should be working toward. And then the adolescent father, kind of the stereotypical role is that they're not involved. They kind of leave the mom after the baby's born. That's what you hear about a lot. I unfortunately see it a lot, but it's not necessarily exactly how it happens all the time. Some adolescent dads stay very involved, but they're going through the same thing she is. They're still trying to figure out who they are. They're still transitioning into their adult role. They feel like they have to grow up. Maybe they feel like they need to go out and get a job and give up their future dreams, to support their new family. So, and a lot of times the relationship with the mom does end, and that can be hard on everybody involved. So just to kind of watch out if you encounter people that are adolescents, to know that they have different needs than your your average postpartum woman and man. And then on the other end of the spectrum, you have your advanced maternal age. So somebody 35 or older is your textbook definition. So basically the biggest thing with that is the social isolation. Maybe they're kind of caught in that sandwich generation. They have a newborn, maybe they're taking care of their parents or their in-laws that are growing older. They don't have all the support that they had. All their friends, their kids are older. They don't have newborns. Their friends don't have newborns anymore, so they feel like they're at a different point in their life. They might have, older children themselves, so they feel like they're kind of stuck. So loss of control, they're conflicting with their career, different issues that they can face. Paternal age, not generally as a significant shift, but there is still some changes in their relationship, maybe some of their work. They're generally a little bit more stable, maybe even a little bit more excited than your average because they finally have a child. They've been waiting so long for this to happen. Another variation of your normal transition to parenthood are your same-sex couples, lesbian couples, or gay couples. I've actually never taken care of a lesbian couple, but I have taken care of a couple gay couples. And that was actually really an interesting dynamic, and it was a good experience for me. So if you have two women, they both share maternal status, that you don't know what they want to be referred to as. Sometimes they say the co-parent, sometimes the non-biologic parent. Reassure them that on the birth certificate, it's just listed as parent, not mother, father, or anything. So just anybody, that's how it's listed. But I've had that come up as an issue a few times. Basically, they're probably facing a lot more misunderstanding and reactions negatively to their choice to have a child than heterosexual couples will have. So to help them adjust to that, give them some tools that they can use to find support, when they go home after the baby's born. And it says that they can participate in breastfeeding, the one that didn't have the baby, and they can. They can stimulate milk production through using hormones themselves, through pumping. They'll use a supplemental nursing system, or they can, if they don't choose to actually induce lactation, they can actually just use a supplemental nursing system and have the baby have the act of sucking. So it's an option for even the mom or the other mom, the one that didn't have the baby, to do as well. So it's a lot of work, though. A lot. Yeah. It's not just something you decide the day the baby comes. Yeah, pumping all the time and trying to induce it. So, yeah, so it is possible, though. The reasons you might see gay couples in there is if they had a surrogate, maybe they're there for the birth of the baby, and that's actually what I've seen a lot of times, and then they have their own room, and then they're there to learn infant care to be there with the baby in the initial time. Maybe they've adopted the baby. We don't know exactly. There's lots of different scenarios of why they might be there, but just know that that's something that you'll probably come in contact with as well. Same kind of issues. They might have stigma out in the community. It's basically your job to give them all the support that you would give to anybody and then not judge them for what you see. Yeah, no judgment. So one of my really good friends, her brother has, him and his husband have triplets that they had via surrogate. So they had a lot of adjusting to do. Yeah, I couldn't imagine, but yeah. So social support, this is for anybody. How much social support they have really helps them to know how they're going to adapt. And you can really see this, especially because we have such an open visiting policy if you work here, because you can see how grandparents interact, how siblings interact, how the the partner interacts with them, and know that it's not always all positive. Those things can lead to a lot of conflict. I see that all the time. I'm constantly talking grandparents down and trying not to have everybody get their feelings hurt for some reason or another. So that's important too, just to kind of watch the whole family dynamic. If you have a parent with sensory impairment, visually impaired, hearing impaired, not really treated any differently. Adaptations that work for their lifestyle, not something that we impose on them. I know there's for visually impaired parents, they can have sensors that flash bright lights when their baby's crying. I said that backwards. Hearing impaired, sorry. I was like, wait a second. Visually impaired parents can hear their babies. Anyway, so just knowing that they might experience some skepticism and helping them to adapt to parenthood the same way anybody else would need to, just giving them the tools that they can be functional with their parent or with their baby. The one thing about visually impaired parents, if they don't have a lot of facial expression, to try to encourage them to be cognizant to try to do something, because their baby will really feed off of the facial cues that they get from their parents, even if they can't see them. The baby's still going to try to make eye contact with that parent. So, hearing impaired, again, kind of the same thing, just adaptations that they need, providing sign language, interpreters, videos, written materials, whatever you can do to help them be successful. Sibling adaptation, big issue for a lot of families. They worry about how the other kids are going to adapt to the new baby. Just trying to reinforce, kids are going to regress. Generally, especially if they're little kids, they're going to have some regression in skills, to expect that to happen, to not push them into adapting to the new baby more than they're ready for. And then just knowing that it's going to take time for everybody in their family to adjust and to be open with that. And maybe assessing support system. Maybe there's somebody that can come in and watch the older kids for a couple hours, and mom can spend time with the new baby, and then someone can watch the baby and she can go spend time with the other kids. Whatever is going to work for their family. And then the last thing I have is grandparent adaptation. It seems kind of ridiculous that we'd even have to talk about it, but grandparents' roles in society are changing a lot. Grandparents are becoming, more of a caretaker for a lot of kids, for their grandkids, I mean. They might be kind of giving unsolicited advice, and I've had lots of issues with patients telling me to get their mom out of there because she's driving her crazy or something. So you might be kind of stuck in the middle of that too. So just kind of know that might happen. So anybody have any questions about anything? That's all I got. That's my baby.
In grandparent roles, it's kind of, when Steph talked about the fact that the mom is driving her crazy and there can be a lot of conflict there. Besides, removing the grandparents from the room.
Yeah. It's not always what we go to. It's just giving them ways to kind of deal with.
Grandparents do have a significant role in the family. They keep the history of the family, and so sometimes nurses can mediate between those two things, kind of coaching grandparents to pull back a little bit, but also reinforcing that role of the grandparents being that kind of tradition maker
Yep.
in the family, kind of
Okay.
teaching
Yeah,
that
it gives
back and
everybody
forth.
value. Yeah.
Because if they're there, they probably usually have a decent relationship. And
Mhm.
you don't want this time to cause a rift
Yeah.
either. So, yeah. And that's an important thing to remember.
Yeah. We do a lot of peacemaking as nurses in any regard, but especially in areas like this where emotions can run really high.
The
So,
whole family.
yeah. Okay. So,
And that's Rhea.
that's my little baby. She's obsessed with her baby dolls right now. So she constantly will feed them. I actually have a photo of her with the baby with the bottle in its mouth on the couch, and she's sitting next to it eating Cheerios. She's like, I'm like, that's a good one.
Yeah, Viv gave Kira a baby doll the first time, and she immediately knew how to hold
Yep.
it, put the bottle in.
Yep, it's crazy how fast.
I don't know, it's in the DNA, I guess.
I think so. So, I had an activity plan, but I really don't think we're going to have time to get anywhere. I was just going to have you guys kind of pair up and do some, like, practice teaching type of things, but I think we got time to probably not.
Yeah,
Not really. Yeah.
I think they're gonna be,
I think you guys
no,
are going to.
no offense, but I think they probably would kind of blow it off.
I'm kind of, yeah. I know. You guys look really exhausted.
I just know that
So.
they are shot mentally,
Yeah.
physically. If you want to come back next Monday, you sure can. But yeah.
Well, thank you again for all the attentiveness and for participating and helping me grow. I really appreciate it. So,
We're off already.
thanks. Thank you.